In CLL, we had this kind of really revolution in treatment with all the new agents coming down the road. We've been really excited about that. There's been great news. We've been kind of saturated with the very positive trial results that we had. At this ASCO meeting, there are some news on the new agents. There's, for instance, the Helios trial combining ibrutinib with BR chemotherapy. But overall, it's more the concept, as you say, that is emerging. And the question is how to combine these new agents, how to sequence them in the future, and how to define patient populations that benefit most from a particular treatment or a particular combination of treatments. As we've experienced the frontline setting, in the frontline setting we use chemoimmunotherapy, so new antibodies like obinutuzumab, like ofatumumab, made it into combinations with chlorambucil, or in the case of ofatumumab also with bendamustine, and kind of challenging, FCR, a treatment which can be delivered only to a small minority of CLL patients. So the benefit of chemoimmunotherapy has become available to a much wider patient population. Now that is first line. And once a patient relapses, which inevitably, unfortunately, is the case after chemoimmunotherapy, and unfortunately for the majority of patients at least, the question then is what you do. You retreat a patient with chemoimmunotherapy, or do you switch to a novel agent? And there, probably the best guidance that we still have are two things, namely the presence or absence of a 17p deletion or p53 mutation, which can occur in relapse even if it wasn't there at baseline. And the second thing is obviously how good the remission to initial chemoimmunotherapy was, or the duration of this remission. And there, 2 to 3 years, probably better 3 years, is kind of the cutoff where you would retreat a patient with chemoimmunotherapy. If remission was shorter, you would probably switch to a novel agent. The universal marker of resistance that there was, like a 17p deletion or p53 mutation, that is very well established in the chemoimmunotherapy era, partly may apply also with the new agents, because we know with the 3-year follow-up data just published in Blood that with ibrutinib, outcome for patients with a 17p deletion is inferior. However, the specific mechanism of resistance that was discovered are the mutations in the BTK gene, so directly in the target of ibrutinib, or in the downstream signaling molecule PLC gamma 2, where obviously activation downstream of the inhibition by ibrutinib can activate the pathway and drive the disease. Other mechanisms to the other novel agents, or in particular to Richter's transformation, which is a frequent phenomenon even with the new agents, the mechanisms of resistance there have not really been elucidated on the molecular level, and this is clearly a critical research question that is remaining.